There are three different classifications on function based on movement. So the first one is synarthroses, and these are immovable joints. And we find these within the tooth adhering to the jaw, our lamboid sutures, for example, as well as our epiphyseal plates in growing bones. The next group is amphiarthroses, and these are slightly movable joints. And so we find these at articulations between the radius and the ulna, and also between the tibia and fibula. And then the third classification is diarthroses, and these are freely movable joints. And so we find these at the elbow joint, at the intercarpal joint and intertarsal joints, as well as with our glenohumeral joint. Joints are also classified based on their structure, and it's on the basis of the type of connective tissue that binds the articulating surface of the bones and whether a space occurs between the articulating bones. And so again, we have three different structural classifications. The first is a fibrous joint, and this is where bones are held together by dense, regular connective tissue. And so for this, there is no joint cavity, and most are synarthrotic joints, but also there are some that can be amphiarthrotic joints as well. Cartilaginous joints are where bones are joined together by cartilage, and so these are usually amphiarthrotic or synarthrotic. And then thirdly, we have synovial joints that have a fluid-filled joint cavity that separates the cartilage-covered articulating surfaces of the bones. And so bones are usually joined by various ligaments and usually have some type of capsule with them. And these joints tend to be diarthrotic, and so allow for lots of movement. Fibrous joints, again, are joined by dense, regular connective tissue. They are immobile or only slightly mobile and have no joint cavity. And there are three types of fibrous joints. The first is gomphosis, and so this resembles a peg and socket, and the only gomphosis that we have in the body is found at the roots of individual teeth at the sockets of the mandible and the maxilla. And so these are held together by the periodontal membrane, and these are classified as synarthroses. And so that's why, for those of you that have had braces before, there's some pain associated with it, because the osteoblast and osteoclast actually have to work together to modify the alveolus within the maxilla and the mandible to remodel that joint and reposition the teeth. Sutures are also immobile fibrous joints, and they are found only between certain bones of the skull. And so sutures are responsible for interlocking and have a distinct, usually irregular shape and edge that increases their strength and decreases the number of fractures found that can occur at these articulation points. And also, sutures help aid in the growth of the skull as we undergo childhood, so allowing for the brain to increase. And so these are also going to be synarthrotic joints. Syndesmoses are going to be where we find articulations of bones that are joined together by long strands of dense, regular connective tissue. And so this allows for slight mobility and are considered to be amphiarthrotic. And so we find this within the radius and the ulna, and the tibia and the fibula, where we have the interosseous membrane that allows for that slight motility at the joints. Cartilaginous joints have bones attached to each other by cartilage, and so these joints lack a joint cavity. There are two main types of cartilaginous joints. The first one is synchondroses, and these are where bones are joined together by hyaline cartilage. Synchondroses are immobile, and so they are considered to be synarthroses. The hyaline cartilage of epiphyseal plates in children form synchondroses that bind the epiphysis and the diaphysis of long bones. When hyaline cartilage stops growing, bone replaces the cartilage and a synchondrosis no longer exists. Another example of a synchondrosis is the spheno-occipital synochondrosis, and so this is found between the sphenoid and the occipital bone, and this synchondrosis fuses between ages of 18 and 25 years of age. A third example is the attachment of the first rib to the sternum by costal cartilage, and so this helps to unify and attach the manubrium of the sternum to provide stability for the rib cage. A second type of cartilaginous joints are symphyses, and so these have a pad of fibrocartilage between the articulating bones. The fibrocartilage helps resist compression and tension stresses and acts as a resilient shock absorber. Symphyses are considered to be amphiarthroses because they allow for sleight of movement. One example of a symphysis is the pubic symphysis, which is found between the right and left pubic bones. And for example, when there is slight mobility to it, occurs when women who are pregnant and undergo childbirth. The pubic symphysis allows for movement of the pelvic bones and to allow the fetus to pass through the birth canal. Another example is intervertebral discs, where the bodies of adjacent vertebrae are both separated and united by the intervertebral discs, where singly, one intervertebral disc allows for very finite movement. However, when we have the collection of all the intervertebral discs and vertebrae, then we have some flexibility that is allowed for our spine. The joint cavity is the space that contains a small amount of synovial fluid, and so it permits separation of the articulating bones, and so helps to reduce friction as bones move at a synovial joint. Lining the joint cavity is the synovial membrane that secretes a viscous oil synovial fluid. And it is composed of a filtrate from blood plasma as well as secretions from the synovial membrane cells. There are three main functions of the synovial fluid. The first is to lubricate the articular cartilage of the articulating bones. The second is to nourish the articular cartilage's chondrocytes. And we have only a small volume of synovial fluid that can continuously circulate to provide nutrients and remove waste. And when we have compression and re-expansion with movement of the articular cartilage, this helps to circulate that synovial fluid into and out of the cartilage matrix. And then the third function of the synovial fluid is to act as a shock absorber. And so this helps to distribute stress and force evenly across the articular surface when there's pressure against it. The ligaments are composed of dense regular connective tissue, and they connect one bone to another and also strengthen and reinforce most of the synovial joints. The nerves and blood vessels supply the articular capsule and associated ligaments. The sensory nerves help to detect painful stimuli in the joint and to report on the amount of movement and stretch in the joint. And so this way the nervous system can detect changes in our posture and adjust our body movements accordingly. In addition to the main structures, synovial joints also have some accessory structures, including bursae, fat pads, and tendons. Bursae are fibrous sac-like structures that contain synovial fluid and line by a synovial membrane. They're found where bones, ligaments, muscles, skin, or tendons overlie each other and rub together. And they're either connected to the joint cavity or completely separate from it. Their function are to help alleviate the friction resulting from our body movements, such as tendons or ligaments rubbing against bones. Elongated bursae are tendon sheaths that wrap around tendons where there might be excessive friction. And so common areas are those found in confined spaces of the wrist and within the ankle. Fat pads are found along the periphery of a synovial joint, and they act as packing material and provide protection for the joint. They also fill the spaces that form when bones move and the joint cavity changes shape. Tendons are composed of dense regular connective tissue where they attach a muscle to a bone. So when a muscle contracts, the tendons from that muscle moves the bone to which it is attached and creating movement at the joint. Tendons help stabilize joints because they pass across or around a joint, providing mechanical support, and can limit the range or amount of movement permitted by a joint. Ligaments also are composed of dense regular connective tissue, and they connect bone to bone and strengthen and reinforce most synovial joints. We have extrinsic ligaments that are outside of and physically separate from the articular capsule, and intrinsic ligaments that represent thickenings of the articular capsule itself. Synovial joints are classified by the shapes of their articulating surfaces and the types of movements they allow. From least mobile to most mobile of the diarthroses, we start with the plane or gliding joint. And this is, again, the least mobile type of diarthroses, where it only allows for side-to-side movements that are possible. Examples of this include the intercarpals and intertarsals, which are the joints between the cube-shaped carpals and the tarsal bones. Another example of this is the clavicle that articulates with the manubrium, which again allows for just side-to-side movement. The second joint that is now a little bit more mobile is the hinge joint, and this is where the convex surface of one articulating bone fits into a concave depression of the other bone. It moves in a single axis like a hinge of a door. And so an example of this is the elbow joint, the knee, and the finger, the interphalangeal joints. More mobile is the next one, the pivot joint, where one articulating bone with a rounded surface fits into a ring formed by a ligament and another bone. The first bone rotates on its longitudinal axis relative to the second bone. An example is the proximal radio-ulnar joint, where the rounded head of the radius pivots along the ulna and permits the radius to rotate. A second example is the joint between the first two cervical vertebrae, where the rounded dens of the axis fit snugly against an articular facet on the arch of the atlas. Condyloid joints are biaxial joints with an oval convex surface on one bone that articulates with a concave articular surface of the second bone. These joints can move in two axes, such as back and forth and side to side. So examples of these condyloid joints are in fingers 2 through 5, where you can flex and extend your fingers at this joint, but also move your fingers apart and back together. And so you have two axes of movement. The saddle joint is where the articular surfaces of the bones have convex and concave regions that resemble the shape of a saddle. The joint of the thumb allows greater movement and is able to grasp more objects because of this type of joint. And the most freely mobile type of synovial joint is the ball and socket joint, because these are considered multi-axial joints, where the spherical articulating heads of one bone fit into the rounded cup-like sockets of the second bone. And so the hip joint and the shoulder joint are common examples where they have movement in three axes. There are four main types of movements that are allowed by synovial joints. The first is gliding, and this is the simplest of movements, in where there are two opposing surfaces slide slightly back and forth or side to side with respect to one another. The angle between the bones does not change, and this is typically found along plantar joints. Angular movements are also movements allowed by synovial joints, and there are several types of angular movements. And basically, they either increase or decrease the angle between two bones. So with abduction, this means to move away, and so it's a lateral movement of a body part away from the body midline. Adduction, on the other hand, is to move toward, and is the medial movement of a body part toward the midline of the body. And so, for example, if you look at your hand and you span out your fingers, this would be abduction, because you're moving your fingers away from the midline. But then when you close your hands together and bring your fingers back together, this would be adduction, where you are moving the fingers back towards a midline. Another type of angular movement is extension and flexion. Flexion is a movement in an anterior-posterior plane of the body that decreases the angle between the articulating bones. Bones are brought closer together as the angle between them decreases. So one example is if you take your chin and bring that down to your chest, that would be an example of flexion, where the angle between the bones is decreased. Extension is going to be also a movement in the anterior-posterior plane, now that increases the angle between the articulating bones. And this is a straightening action that usually occurs in the sagittal plane of the body. And so if you bring your neck or your chin up into looking straight ahead, this would increase that angle, and so now you are in an extension state. Hyperextension is the extension of a joint beyond 180 degrees. So if you take your head and look up at the ceiling, your neck now would be hyperextended. Lateral flexion occurs when the trunk of the body moves in a coronal plane laterally away from the body. And so this movement occurs primarily between the vertebrae in the cervical and lumbar regions of the vertebral column. And so this is where you would, in the anatomical position, say, lean towards the right or the left side with your whole body. Another angular movement is circumduction, and this is a sequence of movements in which the proximal end of an appendage remains relatively stationary while the distal end makes a circular motion. And so you make this imaginary cone shape. So for example, if you extend your arm and make a cone shape, the proximal end will be relatively stable while the distal end is making the actual rotation. Rotation is a pivoting motion where the bone turns on its own longitudinal axis. And so one example would be if you take your hand in the anatomical position and you medially rotate that, then we have the anterior surface of the humerus is medially rotated now to the posterior surface. Depression is the inferior movement of a part of the body. An example of this would be opening your mouth to chew food. Elevation is the superior movement of a body part, and so now this would be closing your mouth, say when you're chewing food. Dorsiflexion is when the ankle joint is bent such that the superior surface of the foot and toes move toward the leg. This movement occurs when you dig in your heels, and it prevents your toes from scraping the ground when you take a step. In plantar flexion, this movement occurs at the ankle joint, and it permits extension of the foot so the toes point inferiorly. So this is like standing on your tiptoes. With inversion and eversion, this occurs only at the ankle joint and the foot. And so with inversion, we have the sole of the foot that turns medially. In eversion, the sole of the foot turns laterally. Supination and pronation is specific to the forearm, where supination occurs when the forearm rotates laterally so that the palms face anterior or superiorly to the radius, and the radius is parallel with the ulna. And this is what we find in the anatomical position. Pronation is the medial rotation of the forearm so that the palm of the hand is directly posterior or inferior, and the radius and ulna are crossed to form an X. With protraction, this is the anterior movement of a body part from the anatomical position. So an example of this would be moving your jaw anteriorly at the temporomandibular joint. Retraction, then, is the posterior direction of the movement back to of a body part back to the anatomical position. So with your temporomandibular joint, moving your jaw back to its original position would be retraction. Apposition is specific to the carpal metacarpal joint, where the thumb moves towards the palmar tips of the fingers and it crosses the palm of the hand. The knee joint is the largest and most complex diarthrosis of the body. It primarily functions as a hinge joint, but when the knee is flexed, it's also capable of slight rotation and lateral gliding. It articulates, or the bones that help articulate with this are the femur and tibia, as well as the patella. And there is not a single unified capsule or synovial cavity that makes up the knee joint. Deep to the articular capsule and within the knee joint are a pair of C-shaped fibrocartilage pads located on the condyles of the tibia. We have the medial meniscus and the lateral meniscus, and they partially stabilize the joint medially and laterally. They act as cushions between the articular surfaces and continuously change shape to conform to the articulating surfaces as the femur moves. So there are many fat pads within the knee joint, and these are all responsible for reducing friction for the articulation between the femur and the tibia. We also have an upwards of 12 bursae that are also found within the articulating capsule of the knee joint itself. There are 7 major ligaments that are found within the knee joint. And the first one, the patellar ligament, this is a ligament that embeds the patella into the tendon and extends from the quadriceps femoris muscle, and the tendon passes over the anterior surface of the patella and then continues on beyond the patella and continues to attach it on the tibial tuberosity of the tibia. The fibular collateral ligament, or the lateral collateral ligament, reinforces the lateral surface of the joint, where this ligament runs from the femur to the fibula and prevents hyperabduction of the leg at the knee. The tibial collateral ligament, or medial collateral ligament, reinforces the medial surface of the knee, where this ligament runs from the femur to the tibia and prevents hyperabduction of the leg at the knee. This ligament is attached to the medial meniscus of the knee joint as well, and so injury to the tibial collateral ligament usually affects the medial meniscus. There are 2 popliteal ligaments. We have the arcuate popliteal ligament, and this is to help stabilize the posterior of the knee. And then we have the oblique popliteal ligament, which this helps to stabilize the lateral side of the knee. We also have the anterior and posterior cruciate ligaments, where they help to prevent movement of the femur on the tibia, and so they form an X shape when they cross each other. The anterior cruciate ligament, or ACL, runs from the posterior femur to the anterior side of the tibia. When the knee is extended, the ACL is pulled tight and prevents hyperextension. The ACL also prevents the tibia from moving too far anteriorly on the femur. The posterior cruciate ligament, or PCL, runs from the anterior inferior femur to the posterior side of the tibia. The PCL becomes taut on flexion and so prevents hyperflexion of the knee. The PCL also prevents posterior displacement of the tibia on the femur. A sprain is a stretching or tearing of ligaments without fracture or dislocation of the joint. Common sprains that occur are ankle sprains when the foot is twisted and always due to overinversion. Fibers of the lateral ligaments are either stretched or are torn and produce localized swelling and tenderness to the lateral malleolus in the case of the ankle sprain. Dislocation or luxation is a joint injury in which the articulating bones have separated. This is often common when you have a hard blow to a joint and is very frequent within the shoulder joint. Common symptoms with this are tenderness and edema at the joint, surface deformities, and a lot of pain because of the significant movement of the bones. Another clinical consideration is torn cartilage, and so this is very common within the knee, especially with the menisci, just due to wear and tear on that particular joint, as well as if there had been a tear previously from another injury that could have affected, say, the ACL or PCL, where there could be damage that had occurred from the tearing and shredding due to the bone that was exposed to the cartilage. And so the menisci commonly have to have some of the torn cartilage be removed so that that prevents those scraps from scraping against bones as well as the fibrocartilage pads themselves. Bursitis is inflammation of the bursae, and this is caused to a lot of friction that occur, and this is very common within our shoulder joint and sometimes within our knee joint. Tendinitis, however, is very common, or is inflammation of the tendon sheaths, and is very common within our hands and within our feet as well as within our knee. And so due to the tendon sheaths that become inflamed, this creates a lot more pain because the tendon sheaths are longer in size than the bursae. Arthritis is a group of inflammatory or degenerative diseases of joints that occur in various forms, but they often have the same symptoms of swelling at the joints, pain, and stiffness. Osteoarthritis is the most common type of arthritis because of its prevalence in weight-bearing joints and its association with older adults. And this is termed the wear and tear arthritis. The entire joint is affected, but the articular cartilage appears to break down first, where eventually bones rub against bones and causing abrasions on the bony surfaces. Without the articular cartilage, movements at the joints become stiff and painful. Rheumatoid arthritis, on the other hand, is an autoimmune disorder in which the body's immune system targets its own tissue and attacks it. There's lots of pain and swelling of the joints. There's muscle weakness, osteoporosis, and other problems with both the heart and the blood vessels that are affected because of the autoimmune disease. How rheumatoid arthritis starts is that the synovial membrane becomes inflamed because of fluid and white blood cells that leak from small blood vessels within the joint cavity. This causes an increase in synovial fluid volume, and thus the joint swells and the inflamed synovial membrane thickens. The articular cartilage then becomes eroded underneath the underlying bone. And so scar tissue then later forms and ossifies, and the bone ends fuse together, thus immobilizing the joint. Gouty arthritis is actually more common in males, and this is due to increased levels of uric acid, which are just normal waste cell products that are found within the bloodstream. This abnormal high level of uric acid leads to urate crystals that accumulate in the blood, in the synovial fluid, and the synovial membrane. And these crystals then result in joint pain and also it can attack a single joint. However, later it progresses to other joints where it can immobilize and cause fusion between the articular surfaces of the bones. Lyme disease is a bacterial infection that is caused by 3 different bacteria, and what that targets are the joints, and they tend to swell, and the knee joint is one that is particularly targeted towards having lots of pain associated with it. Once the bacterial infection has been removed from the body, luckily the pain within the knee starts to decrease, or whatever other joint that is affected with Lyme disease.